Okay, good evening, Professor, Doctor, Sir, and also Madam. Welcome to our first live on Facebook, MD Talks. So I'm very happy because we can meet today. So today event, we hope that all of you can actively participate. If you have any comments or if you have any question, please you can ask directly to the doctor. Yeah. Before we start, I want to introduce a little bit about our Facebook. Our YouTube. The channel is International Medical Forum. Basically, this channel we built so all of medical doctor here, you can share everything related to not only related to COVID, but maybe if you have any update related to metabolic syndrome, diabetes, hypertension, and so on, you can share uh, directly into this channel. So if you really interested to share your knowledge or your updated journal or something like that, please drop your message to our email. This is our email, webinar@kalbeinternational.com. So if you interest with our event, if you want to talk in this event, MT Talks, you can drop your message in webinar@kalbeinternational.com. So before we start, this is a quite interesting article. This is from barely sick with COVID-19 are dying of strokes. So and also if you googling and then you type COVID-19 induced stroke, you can find a lot of news, a lot of study related between COVID and also stroke. So I think it's quite interesting because in Indonesia, uh, we found some cases in patient 30s or 40s. Firstly, they diagnosed with stroke, but later on, when they did a test with COVID-19, I'm sorry, they also have a positive test on COVID-19. So basically, what is the correlation between COVID-19 and also stroke? So I'm quite curious. That's why we made this empty talks, or we made this forum so we can discuss together. Because later on, actually, the goal is we want to identify this patient really gets stroke, or actually a stroke is only the underlying disease from the COVID-19. So we will discuss related to COVID-19 and also stroke. So actually the major point, on the big point, is how does COVID-19 affect coagulation process? Because the key here, especially for ischemic stroke, is coagulation. But before we start with our speaker, which is Dr. Lupita Wijaya, she will share everything related to blood clot related with COVID-19. Don't forget to subscribe, share, like, and also comment in our International Medical Forum. So the channel of YouTube is International Medical Forum. For your information, we will make MD Talks every week, especially in Thursday. So we will change the topic and also the speaker. Yeah, but later on, if you really interested, don't forget to subscribe, share, like, and also comment. And once again, if you interest to be our presenter in this event, you can drop your message, or you can drop your email to webinar@kalbeinternational.com. So without further ado, I will give this session to Dr. Lupita. Please, Doc.
Okay, thank you to Mr. Adit for the introduction. Hello, good night to all doctors. It's such an honor for me to be here and to share about the clot blood in COVID-19 pandemic. So I will introduce myself first. I am Dr. Lupita Wijaya. I am general practitioner from Jakarta. So today we will discuss about the blood clot that related with the overactive immune response in COVID-19 patient. So let's we start the discuss. Okay, in these topics, I will discuss about what the relationship between blood clots with the overactive immune response in COVID-19 patient. Actually, it will be make the multi-organ failure in COVID-19 patient. The topic that we will discuss today is about immune response in COVID-19, normally versus pathogenic. And the second one is the big picture of overactive immune cells. The third one is about pathophysiology of blood clots in COVID-19 patients. And the last one, what does the clinical impacts in COVID-19 patient that related to blood clots? So before we jump into the immune response in COVID-19 patient, we must know, or maybe I want to reminder first about COVID-19 infection. As we know together, COVID-19 infection is the infection that caused by coronavirus or SARS-CoV-2 that it has single-stranded RNA with the size ranging from 26 until 32 kilobases. And then, which ones of organ target of this infection? Actually, there are three organ targets of infection. The first one is upper respiratory tract. It's about nose. And then the second one is about lower respiratory tract. Actually, it's mainly in lungs. The third one is GI tract. And for additionals, there is two else organ targets that may be smooth muscles and also nervous system. And then there is two kind of immune system type. What are they? They are innate immunity and the second one is adaptive immunity. What is the difference between these two kinds of immunity systems? On innate immunity system is usually non-specific immune system and it will appears from minutes until hours. So we can say it fast to release after the exposure to the antigen from our body. And then what the immune cell that include in this innate immunity? There are several immune cells. First, interferon, and then lysozyme, and also the important ones is about complement system. I will give you an example. It's like interleukin 6, and then also interleukin 12, and don't forget, we also have macrophages to phagocytes the antigen when the antigen enters to our body. And then what the immune cells that include in adaptive immunity system? First is lymphocytes. Lymphocytes is divided into two types. First is T cells. It comes from thymus glands. And then the second one is B cells, or we can say lymphocytes B, that usually produce the antibody on several days until weeks after the exposure of antigens. And for the T cells, it usually has the jobs to recognize the antigen 1. And then this is the first important thing that we must know is about normal immune response that happens after our body get exposure to the coronavirus during the infection phase. We can divide it into two parts. First, from extracellular cells, and then the second one is come from intracellular. Don't forget to relate the previous slide. For the extracellulars, we can see the coronavirus. The coronavirus is infects the macrophages. After it infects the macrophage will presents into the T cells. The T cells will be differentiated into two types. First, CD4, and the second one, CD8. CD4 is for recognize the antigen or the virus firstly when it meets the virus. And then the CD4 will stimulate the CD8 to call the B cell to make or produce the antibody 1 for prolonged time after the exposure is about day 7 until day 14 actually. And then don't forget, besides T cell can differentiate it into CD4 and CD8, T cells also can induce the production of cytokines, Th17s. Th17s will produce some complement system that I will give an example at the previous slide. Interleukin 6, interleukin 1, and also TNF alpha. What is the function of this complement system? It's to make the inflammation process after the exposure to help the body to eliminate firstly when the body got exposure to the coronavirus. And then what happened in intracells? In intracells, you can see the coronavirus will bind it into the peptide 4 receptors. And then she come into our cells body, and then in cytoplasm, the coronavirus will bind it to RNA, our body. But our body can give good response if our body has good immune system. So our body will stimulate or activate the TLR3 to stimulate the IRF and NFKB to produce the type 1 interferons. This type interferons is important to enhance the release of antivirus protein to protect our body from the infection of this virus that getting continuous. But sometimes our body can getting weak. So our immune system can be more weak than before. So the impact will be the TLR3 will not be activated. And after that, what the result? The type 1 interferon will not produced by the NFKB. So there will not be the protection for our cells body with type 1 because there is no anymore interferon type 1 from the TLR3. So what we must do? We must do the first thing is to increase the immune system first. And then after that, when the body getting worse after this infection, we must learn about the inflammation process that will be happen after that in several days. And then in this graphic, I want to show the increase of immune cell that happen during the three phase of this infection. COVID-19 infection has three main phases of infection. First, viremia phase is between 0 until 7 days after exposure. And then the second phase is acute or pneumonia phase that happen between 7 until 14 days after exposure. And then the last one, when our immune body cannot more infected by this virus, it will jump into the severe phase that will be happen at days 14 until 21. And on viremia phase, at early phase or the first phase, the T cell is the first one. The red one is T cells. The T cell will increase first to recognize the antigen specifically. And then it will call the B cells at acute phase. At acute phase, the B cell will try to produce the antibody 1 to make or maybe to protect our body from this infection. And then when the severe phase is come into the patient body, the D-dimer, or maybe we can say when the D-dimer getting high, it will be there is an occlusion in our blood vessel that will be the high risk to get multi-organ failure or maybe hypoxemia systemically. And then what we can do to learn about the clinical signs from stage 1 until stage 3. So at stage 1, at early infection, our body can give the maximum immune response to the virus. What we can do, our body will release the first innate immune that we can call macrophages to phagocytes, and then interleukin-6 to make the inflammation process to eliminate at firstly the virus, and the third, it can be recovery by increase the lymphocyte T and B to make the antibody 1 for temporarily. But when the patient come into the stage 2 that we call pulmonary phase, that will be not only fever or maybe only dry cough, but this patient will feel the shortness of breath. In this time, we must increase the maximum 1 of our immune system with immune modulator like vitamin, and then also the immunomodulator one like echinacea, and also the anything else. But we cannot use the corticosteroid because it can make getting worse for our patient condition. But after days 14, actually, when the immune response getting recovery, we hope as the clinician, the patient condition must be jump into the recovery or maybe the rehabilitation phase. But actually, when the immune system getting worse, the stage 3 will not be the recovery phase, but it will be hyperinflammation phase. And in this phase, we can say this is the severe 1 phase of this infection. And the patient not only feel shortness of breath, but they also will feel the sepsis and also cardiac failure, because in this ways the D dimer already getting so high 6 times from normal level. And then what kinds of host risk factors that can influence the overactive immune until become the hyperinflammation? There are several risk factors. The first is about age, elderly mainly, and the second is about smoking. The third, diabetes or maybe another comorbidity illness like hypertension and also cholesterol and so on. And the last one is about the patient that have the history of glucocorticoid use that can make his or her immune system getting lower than normal people, and it will be the risk of getting overactive immune or maybe dysregulation immune response. Because of that, this kind of patient will get into the hyperinflammation process in their bodies. So after the inflammation happen, what kind of impact that influenced by the hyperinflammation? You can see inflammation that described by the increase of leukocyte, the increase of macrophages, and also the increase of complement system like interleukin 6, TNF alpha, and also interleukin 1b. And we can call when the interleukin 6 getting higher and higher, in our body, it will be happen the cytokine storms. And we can say the hyperinflammation has begun. When the hyperinflammation has begun, these cytokines will destruct the endothelial cells of our blood vessel. After destructs the blood vessel, there will be the blood clots that form from the destruction of blood vessel that we call thromboinflammation. Thromboinflammation, we can say this is the thrombus or maybe the blood clot that form or maybe that comes from the hyperinflammation after destruct the endothelial cells of our blood vessel. And besides thrombo formation or maybe the blood clot formation, that the ACE2 receptor that binded by this virus will make the blood vessel getting into vasoconstriction, getting narrow than before. Because of that, the patient not only has the microthrombi or the blood clot, but also will feel the hypoxemia in severe phase. You can see the ACE2 receptors that getting infected firstly or early by this virus. Where is the ACE2 receptor located in our body? Actually, ACE2 receptors is located at several places in our body. The first one in our endothelial vessels. The second one in our lungs. The third, our heart. The fourth, kidneys. And next on GI tract, and the last one is on biliary tract. So you can imagine when the SARS-CoV-2 binded into the ACE receptors on this location of ACE2, that will be happen first, thrombus in our blood vessel that can make the high risk of ischemia strokes. The second one on lungs, the patient will feel the hypoxemia. The third on heart will be happen the cardiac failure. The fourth will be have acute kidney injury, and also on GI tract, that will be another one is about obstruction of ileus or intestinal. And don't forget, the ACE2 also located on our nervous system. Because of that, the virus, after binding into the ACE2 of our brain, it can across the blood barrier system to getting inside into our blood vessel of brain. That will be happen local and systemic inflammatory response. And then because of that, I have said because of there will be the thrombus one in our endothelial cells that we call endotheliopathy, and also we can say the high of production of blood clot because of hypercoagulability due to hyperinflammation. It will be make the severe one that we call hypoxemia in our circulatory system. And after that, what happened? At several organs that ACE2 receptor located will have many clinical manifestation. First, that will be pulmonary embolism, and the heart one, it will be happen the ARDS, acute respiratory distress syndrome. And finally, the patient can have the multi-organ failure, especially in our main organ, like lungs, brain, and also kidney and heart. In our pulmo, or maybe in our lungs, we can see the ACE2 is located specifically at alveoli. Alveoli has the main function to diffuse the oxygens or transfer the oxygens one from our upper respiratory tract until our blood circulation. But because of the alveoli already getting infected by this virus, because this virus already binded into the ACE2 receptors, so the alveoli will not transfer oxygen into our blood optimally. And what happened? It will be happen hypoxemia. But the worst one, when the alveoli getting inflammation and breakdown or getting destruction, the patient will be have hemoptysis or maybe blood cough. You can see this is the hypercoagulation. There is a relationship between hypercoagulation with the multi-organ failure. When there is hypercoagulability, that will be the thrombus and also the blood clot. And after that, what will be happen? The blood clots will be transferred into any organ, especially in major organ like heart, lungs, and also kidney, and also nerve system. Because of that, the patient, the hemodynamic signs of patient will not be stable anymore. So how could COVID-19 impacts the nervous system? We can relate it with the previous slide. Because of there is the inflammation process, the cytokine will disrupt the endothelial vascular, and then after that, the vascular will getting damaged. After that, uh, the vascular our brain that's already distracted will be induced the increase of blood-brain barrier permeability. So this time, the virus have a chance to cross the blood-brain barrier through external transport. And, and then there is several clinical manifestation will be happen into the nervous system of this patient. It will be separated into two kinds of clinical manifestation. First, from CNS, central nervous system, and the second one is peripheral nervous system. And then, as we know, external transport that help the virus getting into the blood-brain barrier, there is the relationship between the external transport with the upper respiratory tract, especially olfactory bulbi. Because of that, at early stage, the patient maybe didn't feel the fever or maybe didn't feel the dry cough, but it will be have hyposmia or cannot smell anymore normally. After the virus getting into the blood-brain barrier, that will be binded into the ACE receptor in our brain. After that, there will be systemic inflammation and also the hypercoagulability in our blood vessel of brain. That will be the high risk to get ischemic stroke. How we can know the risk of ischemic stroke in this condition? We can check some inflammatory biomarkers like the level of interleukin-6, the level of TNF alpha, and also the level of macrophages. According to a consensus of COVID-19, because of this patient will be have any CNS clinical manifestation or maybe peripheral nervous clinical signs, this consensus can mention what signs or maybe what symptoms the patient will be feel after getting infected the virus into their brain. From central nervous system, they will feel one of these symptoms, dizziness or maybe impaired consciousness or maybe epilepsy. And then from peripheral nervous system, the patient will feel one of these symptoms like taste impairment or maybe hyposmia or smell impairment, we can say, or maybe vision impairment until neuralgia. So be careful for the patient with the high comorbidity like smoking and then also elderly people and also have history of the glucocorticoid use for the long time. The inflammation storm will be happen in your body because your body, your immune response in your body already getting errors. So it will be has the risk of the first attack of ischemic stroke or maybe another signs of nervous system like epilepsy or maybe vision impairment. So besides that, what will be happen or maybe what the patient feel when there is the thrombus or maybe there is the blood clots in heart? In heart, because of cytokine storm, the high of interleukin-6 level, the thrombus will be built in cardiomyocytes. After that, the heart cannot be function normally as before. So the pump of oxygen and also the nutrition from the blood cannot be pumped from the heart. Because of that, the first signs will be have arrhythmia, mainly tachyarrhythmia. But if the tachyarrhythmia cannot be solved soon, so it will be cardiac arrest. And then what kind of therapy or drugs that we can use in this situation of hypercoagulability? We can use low weight molecular heparin is about 100 unit per kilogram body weight. And for summary, blood clots formation is began when there is a hyperinflammation in COVID-19 infection. The continuous COVID-19 viral infection could increase high risk of multi-organ failure due to thromboinflammation process. And for the improvement of immune system and antithrombotic are needed to reduce hyperinflammation and thrombosis. That's all about my presentation. Thank you.
Okay. Thank you very much, Dr. Lupita. We found some question related to COVID-19 and also stroke. So first question, let's say if there is a patient came to the hospital, or let's say hospital or clinic, and then the sign is, if we only look the patient, we can see that, oh, this patient is like 90% they have a stroke. But how to identify, because current time is not a normal time, right? So we don't know exactly this patient is really stroke, ischemic stroke, or this is like COVID combination between COVID-19 and stroke. So what we should do as a medical doctor, how to diagnose, is it really stroke or COVID plus, I mean stroke because of the COVID?
I think that we can do first is from anamnesis. So at the anamnesis part, we can give any question to know more about the history of this patient, whether this patient have getting contact with the confirmed one patient, or maybe after that we have the history of confirmed case. We just suspect this patient not only have stroke attack, but also the stroke attack may be related to the blood clots that build after the COVID-19 infection. And after that, we can do two kind of main of tests. The first one is PCR, and the second one is come from the CT angiography for our
CT
brain.
angiography. Okay, so we should assume that all of the patient, I mean especially for stroke patient, they also have possibilities as a COVID-19 suspect, right? So current situation, we should do at least two kind of tests, PCR and also CT angiography. Okay. So the second question, let's say, if because to test with PCR is quite takes time, not only 5 minutes, 10 minutes, and then we can get the result, right? So which one we should treat first, the stroke or the COVID-19 itself?
I think when the patient already suspected to have a stroke attack that related with COVID-19 infection, we cannot treat one by one, but we must treat as the COVID-19 patient. So we do the treat for the COVID-19 infection, and also at the same time, we do the treatment for the stroke signs that the patient have.
Okay. But the main treatment for stroke, even this patient has a COVID-19, still the main therapy is RTPA, right?
Yes, of course. I think our basics it's still from American Heart Association guidelines.
So still RTPA, but in case, because we need to call the ambulance, I mean during COVID,
Yeah.
It's quite takes time to ambulance came, and then the golden period already passed the 4.5 hours, right? If I'm not mistaken, for RTPA. So what's the other therapy or the other drug that we can give to the patient in case late came of arrival in hospital, doc?
Yeah, actually, if we couldn't do the RTPA anymore because it's already more than 4.5 hours from the onset. So we can do the last things. We also can support the neuroprotection with the neuroprotector one, like choline
Okay.
to repair the membrane cells of our brain. Yeah, so the brain will not get more or further distraction because of this blood clot or stroke attack, maybe.
Okay. So citicoline. How about the dose? Is it do we need to give high dose? I mean like 2 gram for the acute stroke acute stroke condition.
Yeah, actually,
Mm-hmm.
from the several countries' guideline,
Mm-hmm.
include Indonesian guidelines, says that at
Mm-hmm.
acute phase of stroke, we can use the high
Mm-hmm.
dose of citicoline to protect our
Mm-hmm.
healthy of brain cells. It's about
Mm-hmm.
1 until 2 grams daily.
Mm-hmm. Mm-hmm. 1 until 2 grams daily, but I believe that 2 gram is more. I mean, will give more benefit for the patient, right? I mean, in terms of time for recovery is faster than the regular doses, which is only 1 gram, right?
Yes, of course. But we must know uh, the the study that explains about unuseful of citicolines. We must consider when you give the citicoline one, you cannot combine with the RTPA at the same time.
Yeah,
Because of
correct.
that, you cannot divide which one the clinical effects that we get. Is it from citicoline or maybe RTPA? We cannot combine.
Okay.
Yes.
Yeah, if not, the citicoline only will be like placebo, right? Because actually they
Yeah.
already get the main therapy. Okay, so the last question, actually the MD talks only until 7:30, but this discussion is quite interesting. So because until now we cannot find the main therapy for COVID-19, right? So what is the other option between, because currently, if I'm not mistaken, they mentioned about remdesivir and then hydroxyquinolone or something like that. But the side effect is quite big. I mean, we don't know yet if we use for long term and with the high dose, right? And then how about with the other another option? Is it because I read also about the vitamin D, if I'm not mistaken, and then vitamin C also, and then what as melatonin or something like that, basically that we can find from vegetables on fruit, right? So maybe you can explain a little bit, or Yeah, just a little bit, because we will discuss deeper about vitamin C, D later on. I mean, next week, right? So we don't stop only in this session, but we can discuss later in the next week. So maybe you can give a little brief doc about the vitamin C, D, and also melatonin, maybe, because that's quite interesting also.
Yes, of course. So we can say from the several studies until now,
Mm.
we can see there are several potential therapy that we
Mm.
can use
Mm.
for these COVID-19
Mm-hmm.
patients. Actually, multivitamin, especially vitamin C, we can use in high dose about 1 gram daily because this vitamin has the highest
Mm.
antioxidant effects to
Mm.
reduce the hyperinflammation in
Okay.
COVID-19 patient.
Mm.
And then the second one about the melatonin.
Mm.
I think when I read, I still unbelievable. This melatonin can
Mm.
suppress the macrophage activation
Okay.
because when the macrophage uh, activate more and more, it
Mm-hmm.
will be make the patient come into the hyperinflammation stage, the
Okay.
severe one. Yes, so
Mm-hmm.
it's like melatonin can control the macrophage activity.
Melatonin. Okay.
Okay.
But we can find melatonin in vegetables and fruit, right? Is it true or not? Because if I try to googling, and then can we find melatonin in our daily food, and then there are some option: fruit, vegetables, and another thing. Is it true that uh,
Yes,
fruit
of
and
course.
vegetable?
When we eat several fruits
Mm.
or vegetable in colorfuls, the melatonins in our body will be getting more higher than before. I think it will be
Ah,
help, but we
okay.
don't know yet
Mm.
when the clinical effects
Oh,
can come
okay.
until after we eat this vegetable or fruits. We don't know
Uh,
yet. I think
oh.
it should be a melatonin supplement maybe at the future. I hope
Talaga.
so.
Uh,
Yes.
and then how about with the vitamin D? Because it's quite interesting also, right? About vitamin D.
Maybe I can say uh, in this country or maybe in Indonesian
Uh,
still have a little products about vitamin
vitamin.
C high dose. So what
Okay.
we can do at early phase when
Uh-huh.
the people didn't have any symptoms, what
Uh-huh.
but they want to maintain to
Uh-huh.
prevent to
Uh-huh.
from the COVID-19 infection, we
Mm.
can use another vitamin like vitamin D and then
Vitamin D.
vitamin B,
Oh, vitamin B.
B1, B3, B6, and also folic acid or maybe B9. We can use this to increase
Oh,
the
okay.
lymphocytes D and
Ah,
B, I think. I
okay,
think
but
it's
actually,
interesting.
yes, interesting, because we I think we can discuss again next week, because
Yes.
for the all of the doctor that join this MD talk. So this is our first show. We cannot say 100% this one is show, right? So if you really interest about our discussion related to COVID-19, and then how about the vitamin, multivitamin, and something like that, I think next week we can discuss deeper about this one. What is the benefit and something like that. So once again, thank you so much, Dr. Lupita, for your time.
You're welcome.
Uh, so uh, I think the your presentation is very useful for the medical doctors. So once again, thank you very much, Dr. Lupita. And then for the registrant and also participation, that thank you for your participation. So if you interest with the slide from Dr. Lupita presentation, you can send the email to webinar@calpeinternational.com. We will give you the slide, so you can restudy again or you can relook again about the presentation. And once again, if you really interest to be our speaker also, I mean from Indonesia, from Vietnam, Philippines, Myanmar, all another country, if you really interest, you want to share 15-30 minutes about your knowledge, not only COVID-19 but another thing also, you can send also the email to us, webinar@calvinternational.com. Okay, thank you for your attention. So we will see again in MD Talks every Thursday. So don't forget to subscribe our channel, International Medical Forum. Okay, thank you and goodbye.